Good afternoon, friends. So we move on with the next session, and that is the aortic valve. First of all, I'd like to thank Jacob for giving me this opportunity to speak today. Okay, thank you. So the anatomy of the aortic root is quite a complex subject, and some of the things I'd like to cover during this talk is that this is a vast area because of the developments in the treatment options for the aortic valve. So the aortic leaflet mechanism itself is fascinating. The aortic root is a small, central, deep area of the heart. And we must keep in mind that there are many new procedures in the last couple of decades. So it's important for the young surgeon to be well versed in the many anatomical and physiological aspects of the valve. So we must remember a genius born a few centuries back, Leonardo da Vinci, who actually figured out how the aortic valve opens and closes, and he was able to decipher a lot of that mechanism centuries back. Now, the Indian connection to the aortic valve are quite a few. So during the course of my talk, I will come across a few Indians who made significant contribution to the anatomy of the aortic root. So among the most well-known of the publications is The Anatomy of the Aortic Root by Dr. Anup Sood. He's a CMC Ludhiana graduate, passed out in 1975, and he's a cardiothoracic surgeon practicing at Detroit. And his publication in the Annals of Thoracic Surgery in 1984 has been the mainstay of the anatomy of the aortic root. These figures that you can see is from his article where he clearly describes the different relationship of the aortic root, the aortic leaflets to the surrounding structures. Yeah. So in this article, he also deals with the complexity of doing aortic root enlargements. So the figures in the center and the right tells us where the incisions are made for the Manugian and the Nix procedure. You go on to the next slide. Yeah. Okay. So there is another Indian connection that we have. We have a biomedical engineer called Manoj Tubrikar, who worked many years with the Edwards Life Sciences Group. So he has studied the aortic valve in detail for the last 20-30 years, and he's gone into the biomechanics of the opening and closing of the valve, so much so that he has produced his own TABI system called the Optimum TABI system. So his publication about the biomechanics goes back 30 years back in 1990. The aortic root anatomy and the adjacent structures, as you can see in this diagram, are very well represented. It's right in the center. It's of the fibroskeleton of the heart. So it's related to the right ventricular outflow tract, the pulmonary trunk, the left atrium, and the right atrium. And so we'll come to this in more detail. While we are studying the morphology of the aortic valve, we have to keep in mind that the procedures which are possible or the options available to the patient today are quite a few. So you have the AVR mechanical valve, the bioprosthetic valve. Aortic valves can be repaired today. You can do a minimally invasive cardiac surgery AVR, then the Bental's procedure, the David's valve sparing procedure. And today we have the rapid deployment of the sutureless valves, the TAVR, And the other problems that one faces as a surgeon is the small aortic root and the bicuspid aortic valve aortopathies. So these are quite a lot of pathologies and options of treatment that we face today, and the morphology of the aortic valve is very important to understand before giving the patient the options of these treatment options. So if you look at the aortic valve options today, there are quite a few. You have the stented valves, you have the stentless valves, you have the sutureless valves, and then you have the transcatheter valves. So all these have a very important connection to understanding the aortic root anatomy. So just skipping through the basics of the aortic root, you know that it is located, you have the right coronary and the left coronary sinus, the non-coronary leaflets. Below that sits the mitral valve. It's closely related to the fibrous skeleton. And on the right, you see the anatomy of the aortic root. So it's a component which extends from the annulus, the aortic annulus, to the sinotubular junction, and includes the sinuses of Valsalva, the interleaflet triangles, and the coronary ostia. The bundle branch is closely related to the aortic valve, so it runs between the non-coronary sinus and the right coronary sinus, and it's in the subaortic segment. I'll come to a diagram later. And the right diagram shows you the mechanism of the aortic valve opening and closure, how the leaflets function. So you have different parts of the leaflets. You have the annular attachment, then you have portions of the leaflet which are called the hinge portion, the belly, and the coapting surface. These are very important to understand if one is planning to do repairs of the aortic valve. The aortic root, you have the true ventriculo-aortic arterial junction, and then you have the nadir of the leaflet closure. So that is what you see in the echocardiogram. So that is the echocardiographic annulus or the virtual annulus. Then you have the mid-sinusal level, where the sinuses are maximally dilated and where the coronary ostia take off, and up to the sinotubular junction, which is the junction between the aortic root and the ascending aorta. The aortic root, it is important to understand this anatomy, that it is a root. The aortic root is anchored by the pulmonary valve anteriorly and by the tricuspid and the mitral valve posteriorly. So it is right in the center. It's integral to the fibrous skeleton of the heart. The aortic root is basically a crown with 3 rings. So the crown is where the leaflets get attached, and you have 3 rings, which is the ST junction, the anatomic ventriculo-aortic junction, and the virtual ventriculo-aortic junction, which is the echo annulus. So this is very important concept to understand, because a lot of our treatments depend on the measurements from these structures. The aortic annulus is basically a scallop-shaped fibrous structure attached to the trigones, the aortomitral curtain, and the muscular and the membranous septa. So it is a complex structure, as you can see in this diagram. If you look at the 2D part of it, you will just see the leaflets arising from the annulus. But if you look at the 3D aspect, the whole thing forms a crown-like structure. The aortic root is a dynamic structure. So during early systole, you can see that the valve is just about to open. During the late systole, you have forces which go from the ventricle to the aorta. And once you have diastole, again, the valve closure takes place where the blood flows back into the sinuses of Valsalva. The ST junction to annulus relation is important to understand. Again, this is in keeping with the newer treatments. We need to understand this relationship. When it is the ST junction and aortic root is pressurized, the sinutubular junction is larger than the annulus. So there is a 1:1.3 ratio of diameters, if you can see in the top diagram. And when it is not under pressure, the annulus is larger than the ST junction. So it is a dynamic structure. You can see that there is a difference in the measurements during systole and diastole. This is important to understand when we use the rapid deployment sutureless valve. So there are some measurements that are taken, both the ST junction and the annulus, and there are some anatomies which are more favorable for deployment of these valves. So the Perceval valve and these other valves are the ones which are commonly used. The role of sinuses of Valsalva. So what Dyron David said was the aortic sinuses have no effect on valve competence, but are important in reducing the mechanical stress on the aortic cusp during the cardiac cycles by creating eddies and currents between the cusp and the sinus wall. So this is an important concept that you know, though it may not be directly look at the competence, it definitely reduces the mechanical stress on the aortic cusps. So this is important to understand whenever we are dealing with the aortic root and doing any repair in this area. So the sinuses of Valsalva, as you can see, it forms a vortex. If you can see that green dot, that is where it forms a small globe-like structure which results in the closure of that leaflet. The aortic leaflets, they are not always all equal. You may have equal cusps and commissures in some cases. In the other cases, you will have unequal cusps and equal commissures. And in the third case, you will have unequal commissures and cusps. So there can be variation they need not all be equal leaflets and equal cusps. And there are variants of the aortic leaflet. So you can have unicuspid, bicuspid, and quadricuspid and pentacuspid. Of this, of course, the bicuspid is the most common variant. The aortic leaflets, this is an important slide for those who would like to attempt doing aortic valve repairs. So from this diagram, you can see you need to understand how these leaflets are closing and opening and what part of each cusp. As you can see in the lower diagram, you can see that a lot of that surface area of the leaflet is the hinge part. Then you have the middle portion, which is the belly, and the one which coapts with the other leaflets is called the coaptation region. So it's important to understand this radial structure of the aortic leaflets. If you look at the right side diagram, then this will tell you the structure of the leaflet. So these are in different regions, the fibrosa, the spongiosa, and the ventricularis. These are all have different functions, and these basically result in giving the aortic leaflet its closing mechanism. So there are some areas which are more fibrous, and the other areas are more spongy and allow that resilience for the leaf opening closing mechanism. Now there's a connection of the aortic valve with Chennai. So this is a publication which came out in Annals of Thoracic Surgery in 2002. Dr. Balakrishnan and Dr. Krishnamurthy from IIT, they actually produced a very beautiful article which looks at the dynamic analysis of the aortic valve. So this is an interesting reading which I would recommend that the young surgeons look at. They've actually looked at how the aortic valve opens and closes. They used a very high computing program to decipher this findings. And here, the other thing about coronary ostia, these are all becoming important to know the intercommissural distance, to know the height of the sinuses, to know where the coronary ostia take place, they takes off because our newer therapies have a lot of relation to where the coronary height is, not only in our routine surgeries, but in the newer therapies, you need to know what is the relationship of the coronary sinus to the left coronary sinus and the right coronary sinus. So these are important information that we need to know in this generation. The aortic regurgitation has been classified, okay, again according to whether they have normal cusps, crust prolapse or cusp restriction. This was studied by El Khoury, and you can see that he has classified the aortic regurgitation into different types, and accordingly he has decided which one requires which repair. The aortic valve repair, which is done by the Japanese group, the Ozaki repair, is another big breakthrough where one needs to know the aortic valve morphology in detail. So he uses autologous treated pericardium to make the leaflets. So these are cut out by special stencils that he provides, and then he sutures it to the annulus in a particular measurement, and this has worked well in his group and some surgeons. The subaortic segment is an important area again. So this is largely supported by the fibrous skeleton, and this is important. This anatomy is important to know the bundle, how the bundle runs through, and also for doing the David's procedure, one must be well versed with what are the structures in the subaortic segment. So you have, just like the previous diagram of the fibrous skeleton, you can see that all the structures are closely related to the aortic valve, and one must know where the sutures go in the subaortic segment area. So this is one of the repairs that has been described, the subcommissural annuloplasty, where proline sutures are taken at the commissures to strengthen the commissures. So this is one of the repairs which is a reasonably easy aortic repair which can give very good results. The aortic root replacement was a breakthrough procedure in 1968. It's called the Bental procedure. This is a procedure, of course, all of us are familiar with. And here one must know the entire aortic root morphology to take a decision whether a patient can get away with an aortic valve replacement alone, or whether the pathology demands that you completely replace the aortic root, in which case the coronary ostia are reimplanted. A modification to this is the David's procedure, where you do a valve-sparing root replacement. And here again, you need to be aware of the subaortic segments. Those sutures go through the subaortic segments and the commissures, and you anchor down a tube graft onto which the coronaries are again reimplanted. The bicuspid aortic valve disease is an entity. It is the most common congenital cardiovascular defect. It has a prevalence of 1 to 2%, and males are more affected. And if you can see, there is a difference in that crown shape of the bicuspid from the normal tricuspid shape. So they have a different anatomy, and the genetic studies have shown that there is some genetic defect, and most of the BAV patients will develop complications over time. So they will have stenosis or regurgitation or both. And the next slide will show us that they also have a preponderance for aortic dilatation and dissections. So the cause of about 50% of adult aortic valve stenosis is still a bicuspid aortic valve, and it is responsible for many of the morbidities for aortic valve aortopathies. There is a important, it's a food for thought. It was observed by Robicek, the opening and closing mechanism of the bicuspid aortic valve versus the three-leaflet aortic valve. So you can see that this mechanism is quite different. And what he found was, if you look at the diameter of the bicuspid valve, which is 2R, versus three leaflet valve, you will see that the total of the coapting surfaces is quite different. If you look at the bicuspid aortic valve, it amounts to 4R, while the three leaflet valve amounts to a total of 6R. So it's an important observation that he has made. Those wanting to repair the bicuspid valve will need to keep these facts in mind. With the newer therapies, it became important to offer some of the bicuspid aortic valve patients better care in terms of TAVI and other procedures. So the bicuspid aortic valve was studied in detail by Sievers, and this classification, where he has a type 0, 1, 2, it basically depends on the presence of the raphe, and he's classified it into different types. And you'll see that the type 1 is the commonest one, where the raphe between the left and the right are fused. As a result of bicuspid aortic valve, you could have an aortopathy. This was studied by Faisal and Miller. So you can see you could have an aortic root dilatation, you could have a tubular aorta, you could have a tubular aorta and the arch, and you could have a diffuse dilatation. So these are from a study by Faisal in 2008. So there's another Indian connection where aortic dilatation in patients with bicuspid aortic valve, a publication in NEGM. This is another very illustrious Indian surgeon, Professor Subodh Verma from University of Toronto. So he's done a lot of work on bicuspid aortic valve, aortopathies. So his publication has come out in 2014, and he's done a lot of other path-breaking research. The TAVR pre-procedure CT assessment is something, again, now surgeons need to know. So there is a protocol for the CT scan where you need to do all these measurements. As you can see in this diagram, you can see that you need to do a lot of measurements of the aortic root, the coronary height, the ST junction. So all these have become important, and it's important for us to know the morphology in great detail. So whether it's a balloon dilatation type or a self-expanding, the planning will be quite different. And here you can see the sapien valve and the core valve. They sit at different areas. One is in the annular area and the other is supraannular. And a lot of CT scan analysis needs to be done. You need to do the contrast enhanced CT images and also the volume rendered CT images. And there is a whole lot of measurements that the radiologist and the team doing the TAVI should be aware of. You can see that a lot of measurements go into planning and deciding the axis and the approach and where to deploy the valve. So this needs a detailed study, and the surgeon needs to be very much part of this team, as he sees the aortic valve in more detail than anyone else. The coronary heights have again become important. So these are studies which showed the post-mortem, the multi-slice CT, and the angiographic heights. So these are the approximate average heights that you will see the left coronary ostium and the right coronary ostium. So these have already been studied and are of immense use while planning these procedures. The TAVR dimensions, so this is a new set of readings. You have the TAVR leaflets, you have a neosinus, you have the native leaflet sitting in the sinus of Valsalva, the anatomic sinus. So this is a whole new set of dimensions and morphology that we need to know. And just coming to the mixed AVR planning, this is also an important part where the morphology of the individual case needs to be studied before you take on these cases. So most of these are done with a CT scan, preoperative CT scan, where you can decide the distance of the bony cage to the ascending aorta, and also the angulation of the aortic valve to the right thorax. So accordingly, if it is suitable, you decide your approach, and then choose your patients carefully to do these procedures. So I'd like to conclude my talk and thank you for Jacob for giving this opportunity. We'll just go on to the morphology of the valve.
Thank you, Dr. Vijit. I think Dr. Vijit will now show you a few structures related to the aortic valve.
Morphology of the aortic root. Here we have a very, we can clearly see the non-coronary sinus. Okay, and this is the right coronary sinus with the right coronary ostium. These are the leaflets there, and this is the left coronary ostium. Here, I think the ostium has been dissected close to this section, and you can see the mitral valve, the anterior mitral leaflet. Let's put this. And once you eliminate this, it's easy to see where the membranous septum is. So in between the non-coronary sinus and the right coronary sinus, so this is the area of the membranous septum, and this is where your bundle would emerge. And here we can see another specimen here where you will be able to see where the coronary could take off. It's a little in depth there. Okay, so these specimens are important to understand if you're planning for a TAVI or a sutureless valve, the approach and where it's going to sit. It is useful to do a dissection of some of these hearts and look at the relationship to the coronary ostium.
Thank you, Dr. Vijit. That was indeed a very in-depth exposition of the aortic valve and also of its significance in various scenarios of current day aortic surgery. This is very important for all surgeons and surgical trainees to be familiar with the current changes that are happening globally in aortic surgery and be abreast with as much as you can. Thank you, Dr. Vijit. Thanks again. Now we have Dr. Suresh. He's one of our senior surgeons here at the Madras Medical Mission, and he would be talking to us about the left ventricle. Over to you, Dr. Suresh.
Good afternoon, everyone. In morphological anatomy of the LV, we briefly see the normal and abnormal and age-related changes. Morphological left ventricle is usually divided into three components: inlet, outlet, and the apical trabecular portion. Compared to the RV, LV is thick-walled and less trabeculated. This is the picture showing the LV papillary muscles. This is the echo picture of the same. Clinically, we are seeing the left ventricle shape is approximate to a cone with the right ventricle hugging around it. Since it is a cone, septal component of the left ventricle is curved. When viewed from the anterior aspect, most of the LV is hidden by the RV. Other than that, the LV outlet usually overlaps the inlet. The left ventricular free wall is thickest at the cardiac base levels. It's around 12 to 15 millimeter. Goes gradually thin towards the apex, even up to 1 millimeter at the level of apex. This is the diagram showing the cross section, longitudinal section of the portions of the inlet, outlet, and apical portions. Note the crisscross relationship of the RV and the LV outlet tracts. The other right side panel is showing the broad muscle bundles and the trabeculations. The lower one comparable to the post-chamber view of the echo of a dilated ventricle. We see the LV myocardium. Bulk of the LV myocardium is formed by contractile cardiac myocytes. Only a fractional volume of collagen is small. Usual adult cardiomyocyte is 120 nanometer long and 20 to 30 nanometer diameter. Each myocytes branches and adjoin with the adjacent myocytes, forming a complex three-dimensional network or syncytium of the anastomotic fibers. The extracellular matrix is usually divided by epimysial and perimysial and endomysial components. Each myocyte is surrounded by fibrocartilaginous connective tissue, which is providing supportive framework that called as endomysium. And group of myocytes are enveloped by the connective tissue known as perimysium. Any abnormal accumulation or change in the quality of the connective tissue increases the myocardial stiffness. This is the diagrammatic representation of this endomysial V1 studs and perimysial V1 studs of the coil fibers. The lower picture showing the anterior, frontal aspect of the heart, slightly rotated to show the more of LV, showing the superficial, oblique and middle circumferential and deeper longitudinal fiber orientations. When we considering the ventricular myoarchitecture, two schools of thoughts. One is the discrete system of myocyte arrangement in each ventricle. The other school, single rope-like configuration encompass both ventricles. Actually, the layers represent only change in the orientation of the muscle fiber strands transmurally, not anything separating its cleavage. Superficial layer or oblique fiber forms around 25% of the wall thickness. The middle circumferential is the most thickest part. It is a form around 50 to 60% of the thickness. The deep myocardial is the thinnest one. Oblique fibers forms around 20% of the wall thickness. This is a diagram showing the fibril myoarchitecture of the left ventricle, two helical system and single rope system. The left panel showing the clockwise, one outer clockwise and inner counterclockwise helical system. The left side is showing the hawser kind of single consists of multiple ropes helically twisted around each other. This one structure is the form for the torsion motion of the LV. When we considering the collagen network of the heart, the collagen concentration of the RV is approximately 30% greater than the left ventricle because the myocytes are smaller in size comparable to the LV. The interstitium of the myocardium usually includes the fibrillar connective tissue, fibroblasts, plasma cells, and gel-like ground substance composed of glycosaminoglycans and the glycoproteins. The dominant components of fibril connective tissue is type 1 and type 2, type 3 collagens. Type 1 collagen is tensile strength usually equal to that of the steel. This is the cartoon representation for the same myocardial cells supported within the scaffold of connective tissue. This fibrous matrix consists of short studs fixing the myocyte to myocytes to the capillaries. Each myocyte will be wrapped by the fresh mesh of collagen. This matrix is giving the freedom of motion of myocytes in all three spatial coordinates. This is the actual electron microscopic image of the endomysial fibers or studs seen in myocardium. This is a diagrammatic representation of the endomysial fibrils inserting the Z band of myocytes. It is communicating with the intermediate filaments inside the cells. This is another electron microscopic picture. In unstretched muscle, these collagen fibers have a complex arrangement. Whereas in the stretched muscle, they will arrange it parallel to the muscle fibers. This is the MRI image of interventricular twisting motion during the towards apex ejection. In the pathological condition, the collagen matrix remodeling occurs like pressure overload states. There will be increase in the collagen concentration. Both structural and biochemical remodeling occurs. Actually, myocyte and collagen compartments are under separate control, but they have also a common controls also. Myocardial collagen concentration usually 3 to 6-fold increases in the pressure overload status. Other than that, collagen degradation also increases, but that usually returns to normal quickly than the deposition. These increased dimension and the number of interfascial perimysial strands. This pattern is key fibrosis. It's representing the structural remodeling when usually occurs in the LV. The reactive fibrosis is a form in which there is no need for the myocyte necrosis, but later stage when there is a cell loss, it will be replaced by the reparative fibrosis. When these are combined, both the diastolic and systolic LV dysfunction appears. This picture showing the normal and dilated cardiomyopathy. What is a change in the perimysial epicardial arrangement of the muscle fibers? There will be fiber slippage and wall thinning because of the disruption in the tethering. There's another diagram showing the normal elliptical shape is changing into the spear-shaped heart, and there is a loss of apex kind of due to the differentiation changes in the fiber orientation in case of cardiac failure and dilatations. And we finally see the changes related to the age. Usually intermolecular cross-linking of the collagen will be increased in the increasing age. That insoluble collagen levels will be increased in concentration. Within subendocardial deposition causes muscle stiffness. Because of that, myocytes loses its function, so unloaded myocytes becomes atrophic. This is the picture showing the young and aged myocardial changes. Myocyte loss due to the apoptic and necrotic pathways result in hypertrophy of the remaining myocytes and replacement fibrosis. This perivascular and the reactive fibrosis due to the deposition of the collagen. There will be post-translational modification of the collagen also, because enhanced the cross-linking of the collagen. These are all shown in this picture. Okay, thank you.
Thank you, Dr. Suresh. That was indeed a very good and very concise, and as well as a very you were kind of showing us what we normally wouldn't see in the left ventricle. So we were quite happy that you could open our eyes to seeing things in the left ventricle that we normally don't see or normally don't even think about. So thank you so much. We thank you that you've been part of our team today. Now I'm going to show you two things. One is we have Dr. Shiva here, who is a leading pathologist in the city, and she would show you things that you normally don't see. And I will, at the end of her talk, I will also show you certain things which you normally don't see on table. Things to do with the base of heart. So we would show you a deatrialized specimen of the heart and the interrelationships of the valve. So that would follow the talk on things that you normally don't see, normally that you need a microscope to see. So over to Dr. Shiva, pathologist.
Good afternoon, everyone. Now we are going to zoom inside the heart and see the cells magnified from 100 to 1,000,000 times So first we are going to see the pericardium. So this is the horizontal cut section. You can see the visceral pericardium and the parietal pericardium and the space in between. The pericardium envelopes the heart. It's a fibrous structure lined by mesothelial cells and can have adipose tissue. The parietal pericardium is reflected off the ascending aorta, the pulmonary trunk, the terminal 2 to 4 centimeter of the superior vena cava, and the distal segment of the inferior vena cava and the pulmonary veins. It is inelastic and up to 50 ml of fluid can be present, but if there is more fluid accumulation and it is acutely stretched, it causes cardiac tamponade. Heterotopic tissues like thyroid and thymic elements can be present and it should not be mistaken for metastasis. So this is a descriptive picture. So you can see the You see the multiple layers of the heart. So this is the parietal pericardial layer lined by mesothelial cells, and there is a fibrous tissue, and this is the visceral pericardial layer over the myocardial cells. And this is the inner surface. So this is a light microscopic view. So of the pericardium, it is lined by mesothelial cells on the surface. This is a fibrous tissue and this is the adipose tissue. So this is a visceral pericardium, the layer of mesothelial cells beneath which there is adipocytes with nerve bundles and blood vessels. So this is a scanning electron microscopic view of the pericardium. So you can see the surface lining by mesothelial cells and there are adipocytes in between, and these are the reticular supporting fibers. And here you can see the cross section of a coronary artery, and you can even see the inner elastic lamina very clearly. And so this is the endothelial lining of the coronary artery. So this is almost a million times the magnification of the adipocytes, and you can see in the inset you can see the coronary vein. So this is part of the blood vessel. You can see the lining endothelium. This is the cut surface of the myocardium.